Hello, everybody. I thank all the participants of this 7th webinar organized by Movendo Technology in collaboration with Maragal Medical. Before starting, I would like to thank Michael Marciello and Colleen Gallagher, who will talk today about use of HUNOVA with the regenerative medicine therapies. At the end of the presentation, we will open a question session, and you can speak directly with our clinical expert by clicking the red arrow at the top to open the control panel. And below, you'll find a series of functions, including the hand symbol. So you have to click it to ask to speak. I now pass the speech to Michael Marciello and Colleen Gallagher. Thank you.
Well, thanks for waiting. I hopefully can keep us all in tune here. And welcome and thank you for introduction. And we hope to pass along a very basic cursory type of program for our practice and ways in which we are using HUNOVA for our clinical outpatient practice. Again, my name is Michael Marciello, and this is Dr. Colleen Gallagher, our Director of Physical Therapy. And we'd like to have a little bit of time sharing with you the way we have started using HUNOVA in our practice. We've only been doing it for since last fall, 7 or 8 months, of where we're trying to get more and more knowledge of how to use the HUNOVA device to gain more understanding of how we can modify our treatment protocols and develop a program where we are using regenerative medicine in our practice. We are an integrative medicine practice where we combine physical medicine, chiropractic, physical therapy, and regenerative medicine injection treatments to help musculoskeletal and neurological disorders such that we can figure out how best to treat our patients, looking at their function and hopefully improve functions over time. Here we go. If we look at the aspects of what's some basic information in relation to regenerative therapies, there are different types of regenerative therapies: stem cells, PRP, exosomes. There are a lot of things that are being done across the world, and in America, we are certainly expanding on these services. In our clinic, in the stem cell injections, we use amniotic allograft or amniotic-derived stem cells. You could also harvest the stem cells from bone marrow aspiration, where either through the hip or the pelvis, the bone marrow is aspirated, put in a centrifuge to spin and take that layer of stem cells to be re-injected into a damaged tissue or joint of arthritis. And there are adipose-derived stem cell, where you can obtain the stem cell after you withdraw some adipose tissue from a person. You put it through a wash and then develop a program where the stem cells are injected. That currently is on hold in America as the FDA is looking at the utility and ways in which we can use adipose-derived stem cells, and that's going to be reevaluated with decision if it can be used in November. PRP is another solution that we are using in our practice. It's called platelet-rich plasma. It's a way that we take an autologous whole blood withdrawal from a patient, put it in a centrifuge. We spin it down to get the platelet layer. You can have a platelet leukocyte-rich or leukocyte-poor level. We take that solution and re-inject it into tissue, soft tissue such as tendon, labral tissues that may be damaged, such as a hip joint or shoulder joint, and we see if the reparative properties of growth factors and collagen and products that can help improve a destroyed or destructive joint. Exosomes is another concept that is getting more and more popular across the world. It is looking at small particles, so-called vesicles, that are essentially cell-to-cell signaling proteins that help the body use its own natural stem cells by giving it a signal to bring in messenger RNA, proteins that help the body to promote healing. And we are also using that either through an infusion process or by direct injection. So currently, the use of stem cells in regenerative therapies are looked at from most commonly used as intra-articular joint injections for an arthritic joint, such as a knee or hip arthritis. You could do a periarticular injection, such as you would get around the joint as a ligament or ligament damage and try to help repair. You could do peripheral nerves, and we'll describe a case of that a little bit, where we inject around the peripheral nerve, hope to have some healing and regrowth, and as well as tendon repair, labral repair, as we mentioned before. In the future, there are going to be more look at more neurodegenerative processes, disease processes such as Parkinson's disease, multiple sclerosis, Alzheimer's, ALS, stroke, and the neuropathies that we are doing currently. The conditions are not necessarily understood how best we are treating with stem cell or regenerative therapies, but it's investigational and being looked at more and more, and hopefully innovative way to treat some of these patients in the future. So a little bit of basic anatomy. As we think about some cases we're going to present in a minute, we're going to look at some really just simple concepts. Well, here's an x-ray of on the left-hand panel is a normal joint. The joint spaces are open. We don't see any destructive sclerosis or bone spurs that we will see on the right-hand panel. So if you look at that right-hand picture of a knee joint, you have loss of joint space both on both medial and lateral side. The increased white there is the sclerosis with bone growth as a bone spur, osteophyte, and that we see as a typical candidate or person who has that knee joint problem to receive a regenerative injection. But in our clinic, we wanted to start thinking about, well, how do we get some knowledge and objective evidence to know if that actual injection is making a difference? There are some studies out there that looks at MRI studies that show, well, perhaps if we get a repeat image after injection, we may see some increased space. But it's not very clinically helpful to know if we're really getting much benefit to the injection other than maybe subjective, and a repeat image may not help us. So we wanted to get a little bit more objective and find a device or find some way that we can use other means of measurements of success or evidence that we are actually making a difference. So I'd like to present a bunch of cases. We got 4 cases that Colleen and I will review, and we're going to go through those as a basic kind of examples and types of conditions we treat in our clinic, and hopefully we can kind of bring up the thought processes across all our viewers today to see what types of things you might think about when you're using a HUNOVA device in your outpatient practice. So here's just a little cartoon that we think about the start of our patient's day is at the time of their injection. So looking at a timeline, we get the day of their injection is the day that they start getting some information. We start a process of physical therapy assessments. We look at their function and activity, and we look to see how we can improve through a rehabilitation type of setting. Well, how do we collect that data over time? We are now using the HUNOVA. What a wonderful device that we can now collect the data through the computer and look at research techniques, look at the information and analyze that to decide, all right, what do we do to make this patient more functional? Can we improve upon their joint range of motion? Can we make them less pain? Can we look at the aspects of returning to their work and things that all of us in the rehabilitation world look at? And so we are just finding the tip of the iceberg in relation to the data that can be collected in HUNOVA, and we are starting to do our research protocols. So let's look at some simple starting points. Give your first case, and then I'll jump to Colleen and see if she can kind of give us some understanding of what these patients have gone through in the rehab protocol. So the first case is CC. He is a 46-year-old man, healthy runner. He presents to us after about 8 months of having right knee pain. He is deconditioned as a result of having a twisting injury to his right knee, and that had resulted in his inability to get back out running and doing the things he enjoys. He gained weight over about 6 months following the injury. He was not running. His BMI was increased, showing that he had gained some weight, and now he has some numbness, some myofascial tenderness in the buttocks and lateral hip pain, all likely compensating because of his knee injury. His treatment in the past was rather simple. He used some over-the-counter anti-inflammatory medicines. He did relatively some therapy or home exercise program, and there really was no change clinically. He came into the office, had gone through an evaluation. We got an MRI that confirmed the pathology was a medial meniscal tear. It gave us explanation of what was happening, and now we see on his examination that confirms that there was no radicular component. His exam was more straightforward, that he had a knee pain, a knee problem, and he was developing some of this additional myofascial referred pain. We got him on HUNOVA. We identified that there was some abnormal findings, and we'll go through that in a minute. So what treatment do we do for this gentleman? So we put him on.
Go ahead.
On the injection, we've got an amniotic allograft injection, and we combine that with PRP and look at a knee brace that we do as a protocol post-knee injection. And with PT strengthening, we held off in his cardiovascular exercise. And now I'll let Colleen kind of fill us in how repeating the exercise and HUNOVA assessments can help us in this case.
So for this gentleman, when we did the physical therapy evaluation, he was very strong overall. It was hard to find areas of weakness, but he did have pain in the knee, but it was hard to objectively show where his limitations were. But then we put him on the HUNOVA, and we noticed that he did his single leg standing on his uninvolved side, and it was pretty normal. And then as soon as we put him on his injured leg, he could not get towards midline. And we could really see at that point him really trying to struggle to get centered on the machine. And then you could really see some of the hip weakness, unable to stabilize at the pelvis and keep that level. So the HUNOVA helped us to find like an objective starting point. Although his manual muscle testing might have been 5 out of 5, he really wasn't as strong as he should be, and then comparing it to the other side. So this was able to give us some data as a starting point, and then to see where he was. So that when he came back 3 or 4 months later, we did it again, and he reported much less pain. He was starting to get back to his activities and everything. But again, how do we show objectively that he improved? So again, we put him on the HUNOVA, and we did, single leg and double leg and squats and things like that. But the biggest difference again was we're putting him on the single leg and looking at his left leg, which was normal. He could kind of stay in the center, and then that right leg, he still had some difficulty getting to midline, but it was much more. He didn't struggle as much. His hips weren't dropping. And it was just nice to be able to compare those two, and then we'll be able to do it again in another 3 or 4 months for a year, and have some data to show how the decrease in his knee pain itself has allowed him to have more function and limit injuries to other areas by compensating.
Great. And we think about this case as a very more straightforward single joint, a regenerative medicine injection, and a physical therapy program, but teasing out those details that Colleen just described helps us really look at the picture other than clinically only with the PT directly with patient. We got the HUNOVA to give us some more details. So let's go to the next case. We'll mix it up a little bit more complicated, or maybe perhaps a lot more complicated. Here's a DP, is a 77-year-old diabetic man. He presents with chronic lower back pain, left greater than right hip pain. He has balance deficits, numbness and tingling in his feet. He's got weakness, both legs. And in his review, prior to coming to us, we knew that he was having frequent falls. Pretty much for 5 out of 7 days, he was having some near falls or falls. Very sedentary. He became obese. His BMI, my gosh, at 47, and had struggles terribly. He was motivated, so we wanted to try to see what kind of treatment we can get him. His past treatment before us was over-the-counter medications, prescription anti-inflammatory medicines, formal physical therapy, and cortisone to his hips, as well as his spine in the form of an epidural injection on 2 separate occasions. They may have given him some very temporary relief, but certainly did not give him long-lasting relief. Diagnostically, we had some x-rays which showed both severe hip as well as knee arthritis. He had lumbar MRI showing multi-level degenerative disc with stenosis, facet arthropathy, and all the degenerative changes you would expect to see. On examination, his pain levels were high, 7 out of 10 intensity. He was an overweight man, limited hip, knee, back range of motion. He was unable to stand on single leg, clearly identifying that he was at a falls risk with his weakness and having troubles in both legs and in his core muscle groups. So basic treatment from a regenerative medicine standpoint, we had a lot of things to look at, but where do we focus? Well, we started at the lower back. We gave him an amniotic allograft injection at levels L through L5. Now that would be a periarticular facet level injections at those levels, and started simple walking. We gave him walking poles. We try to prevent him from falling. We wanted to see how we can get him so we prevent his falls and prevent injury. At the same time, we start the physical therapy. We are looking at ways we can use HUNOVA, and after treatment did much better, no falls. And Colleen, fill in this one with knowing that it was much more complicated than our first case.
Right, so this is a good example of someone who is deconditioned. He is weak everywhere. He has balance problems. He has mobility problems. So kind of like, where do you start? So we started out with the HUNOVA assessment, and at this point we kind of made up our own for him. And I think now moving forward, we would use the Silver Index, which is a really good assessment of a fall risk. But at this time we were trying some new things. And so we got his initial evaluation on the HUNOVA, nothing to compare it to for him. So we kind of just tucked that away till later. And we gave him a good home exercise program, really focusing on hip and knee strengthening exercises at home. And then he came in twice a week. And for about 30 minutes, we worked on the HUNOVA. And so we did mostly standing exercises for about, the 8-minute time frame, and then the seated exercises, which were good for him because he could only really tolerate, standing for 8 to 10 minutes of exercise. And then we were able to put him in the seated one, which really worked on his core stability, just to kind of give him some feedback. It was, hard for him to even know what his core was, why it's important. And he could really see on the seated platform that was unstable, how you have to activate those muscles to kind of stay level. And so for him, he wouldn't really be able to use the HUNOVA if he didn't have some type of assistive device or holding on to the rail. So we decided to let him try something new and let him use his walking sticks on the HUNOVA, as well as being guarded and supported by me. So in the beginning, I really had to support him for most of it with the gait belt and his walking poles. And I really found that he continued to kind of lean backwards, and that's probably why he was falling more, is he just couldn't get his weight forward even though he had the walking poles. So we could put him on there on unstable surfaces, and he could track on the monitor where his center of gravity was, and it would remind him that you need to put your weight a little bit forward. So we thought that was more a functional carryover, because he's going to be walking with the walking poles. He's not going to be walking without them. So why not work on his balance with them and make it a little bit more functional? So we worked on, so on the HUNOVA, you can do active and some passive and even some strengthening. And I found that the lower level active and passive were better for him. The strengthening with some squats and things like that was not doable at all. So he was able to do the easy active and passive, and eventually moved up to some medium exercises. And then each time we did his assessments, he just continued to improve more and more. So his scattergrams became smaller. He was able to keep his center of gravity a little bit tighter, and the limits of stability, he was able to reach out a little bit more. And the biggest thing that we were happy to report is he went from falling like several times a week to he went like several weeks without any falls. He had one that was slipping on ice that any of us would have fallen, but he really changed that. And then he was able to go and start pool therapy because he was able to get in and out of the pool. He got, he was on a weight loss program. So all these things encouraged him to kind of get back into shape and really decreased his fall risk.
Yeah, so there's a case that has just so many facets to what to work on, and we believe that the regenerative medicine had helped reduce his pain levels, and we were able to start getting some of these treatments, because bottom line is the other type of procedures, injections or therapies weren't carrying over for long enough. So he sustained the exercise program through the whole program with Colleen, and really seeing some improvements And again, hopefully in time, this will hold longitudinally and we will still see his progress. So let's go for a little bit, again, different twist. Here's another patient that seemed a little bit more straightforward. It's EL, 79-year-old woman, retired teacher. She presented to us with chronic lower back pain and chronic right shoulder pain as she had required surgery for falls in the past. And she had this chronic shoulder problem for which she heard about us as a regenerative medicine practice and was interested in potentially getting a regenerative injection to her shoulder. But when she presented, she gave us her review of systems. She described her falls. She described her history of the shoulder dislocation and multi-directional instability. That's the one that required surgery. She was very protective of it. She had, again, difficulty with activities and perhaps maybe making her balance and her lower back pain worse. We noted that diagnostically, she had diffuse lumbar spondylosis. She didn't describe a lot of back pain, but yet certainly was there. And with the disc degeneration for facet arthropathy, we figured we need to address this lower back problem. On examination, she certainly had some discomfort to palpation. She was weak in her hips, specifically on her left side, and single leg stance was difficult for her. But we tested her on HUNOVA. We found that there was some abnormalities, and we'll review that. But what was different about this is that we started to think about how do we take this person who comes to us for her right shoulder and knows that in review that we have a back problem, do we inject both the back and the shoulder, or do we look at different processes? So we get her on the Silver Index, and we have a standard protocol by HUNOVA. And Colleen, walk us through with this case.
So she was very motivated and was really good about her exercise program. So we started her on the HUNOVA, and as you can see, she was at a high fall risk. So watching her walk around and come into the clinic, you wouldn't really think that. She looked pretty good for her age and physical activity level. But again, so we started using the Silver Index to kind of give us a measurable outcome. So she got the 92%. Then she worked on the HUNOVA at least once a week for a month, and I gave her a good home exercise program. So she worked a little bit on balance at home and a lot on strengthening. And then she came back. After 4 weeks, I did a reassessment with her, and she wasn't really having any pain in her back or her lower extremities. And then she got a 62, which kind of put her in the orange-yellow range for fall risk. So definitely a really good improvement. And so we decided to continue, and it's still in the risk. And then last time she came in, she was down in the yellow. She had a 35% fall risk, and she was just very excited, and it gave her good feedback, and she felt more comfortable, and she could really feel how her balance had improved. So I really like that the machine was able to give us some objective data, and it kind of gave the patient some reinforcement that yes, you're doing the right thing. Look, it's not just in your head, you really are doing better.
And this is a case that from a clinician's perspective, it's so easy to just try to treat the diagnostic studies. We see the diffuse spondylosis for lower back, we see the degenerative changes, and it's very easy for us to provide an injection to those levels. But just looking at the HUNOVA data and seeing the progress over 1 to 2 months, and seeing that there was actually improvement, we realized that here's a perfect example that we can now focus regeneratively on her shoulder, but mechanically she just needed some good exercise, training with HUNOVA and PT, see that her falls risk reduced, and recognize that this doesn't necessarily require injections that we might do from only looking at the x-rays or the MRI reports. And so it's a wonderful explanation, or at least example, that shows we're changing our clinical treatment based on what we're seeing on HUNOVA data. So let's give it a last case. We'll bring it to this gentleman. Is a BR. He's a 49-year-old man, complained of paresthesias, left greater than right foot. Both hands also had numbness and tingling symptoms for about 5 years. He presented to us with chronic lower back pain since 1992 and this terrible neuropathic symptoms of both his hand and his feet. That neuropathic symptom was disrupting his sleep. He had loss of balance. He had bilateral foot pain, and he was obviously struggled, especially relatively young age, of dealing with this neuropathic process. Testing-wise, he had an MRI that proved that he had lumbar spondylosis. He had disc degeneration and facet arthropathy, mostly at the lower couple levels, the L4-5 and the L5-S1 levels, but it didn't quite explain why he was having such symptoms to his feet, and certainly wouldn't account for the hand symptoms. And before he got to us, he did go through a lot of neurological studies, and eventually he underwent a skin biopsy proving that he had small fiber peripheral neuropathy. Well, we know that is more of a systemic neuropathic process and a neuropathy of which we wanted to see, could we set up a protocol and treat him with regenerative medicine practices and then use HUNOVA to help us out. So what did we see on his exam? Well, he had tenderness to his lower back. He had a negative straight leg raise, so it did not show any signs of an acute radiculopathy to account for problems. He had relatively normal strength, with the exception of for the most distal portions, had repetitive toe raises and some EHL weakness. And again, we would expect the HUNOVA assessments were abnormal. If Colleen can go through this one, it'd be quite interesting to show how we treat a little neuropathy symptoms, different perhaps, but similar to the other cases.
So again, this is a good example of a gentleman who is clinically very strong. He did, he was an athlete when he was younger. He does a lot of coaching in sports with his children, and he's a very tall, large gentleman. So again, when doing physical therapy, manual muscle testing, he was very strong in every muscle group. But again, you put him on the HUNOVA and you can really see the breakdown where the single leg activities were really difficult with him. And even though the strength difference on the side that maybe had more of a neuropathy than the other, you couldn't tease that out with manual muscle testing. When you put him on the machine, he definitely started to just kind of feel some fatigue happening in that leg. It just could feel, it felt a little bit different. So for him, I really challenged him and used the HUNOVA on like the hardest setting for strengthening. He did lunges and he did squats and he did lots of uneven balances so the platform can move in different angles, and it was really steep angles, and he enjoyed it. He found it challenging, and you get some of these athletes and they want to get in there and they want to beat the machine, and they're just really excited to try some different things, where if you had just a regular balance equipment in the gym, it can't mimic what the HUNOVA can do. So we could really challenge him. And so I saw him for several months, and he would always come back in and say, I feel the same, my symptoms are the same, maybe I can stand all day and not feel quite so fatigued in my legs, but I don't know if that's really true or not. It just, sometimes I feel better than others. So it was good, again, to be able to get some objective data and really show that as he worked on the machine, and I did give him, some ankle exercises. I give him ankle exercises at home. We did ankle strengthening, calf stretches, and then I did work on his core and his hips as well. Even though they weren't weak, for that type of individual, he just needs to be even stronger for his type of physical work and activities. And then as he would come back, he showed improvement on the HUNOVA. So it was nice that although he couldn't report any improvements, we could prove to him that all your hard work is paying off. You are significantly better. Even though you may not feel it, here's your proof. You are better, you have better balance, you have better strength, and here's the documentation. So that was kind of nice to be able to show someone who might be getting a little frustrated with the performance that, no, you are doing everything right, you are improving.
That's a great comment about the frustration, because we as clinicians, of course, we also think we get frustrated for our patients not knowing what next to do. So without the HUNOVA in this case, we would be just going right back to the same thing that he's expressing and saying, I don't know what to do. I'm not sure what to do because you're still having the same symptoms. But it really identified to me that this person has two separate problems for sure. We know he has diagnostic neuropathy problems, but his deconditioning or his back issues was not the primary issue. He was able to improve on the HUNOVA. He was able to show these objective numbers so he can encourage to stay with his exercises. And then I have, as the clinician, have to work on his neuropathic pain problems, because that is now a separate issue that will be independent to what we see on the exercise equipment. Once again, we've injected him. We gave him direct amniotic allograft injections to the nerves of his feet. We know in the neuropathy protocols that this is going to be more likely longer to take effect than it would be a straight joint injection. And so it's encouraging to say, you know, we still have some hope that we can get some further improvement because we see this comparative data over the course of time that's much more objective than any of us would pick up clinically. So those are some great cases that we see in our clinic. And as I mentioned earlier, we've only been doing this for 6 months or a little bit longer. So we are looking at individual pathology. We're so happy to have the HUNOVA machine to know that we are looking at different pathologies for what might come into our clinic as the same problem. Hey, I have balance problems. I have joint problems. So we look at the musculoskeletal patient, knee arthritis, hip arthritis, ankle arthritis. You know, we had to address those patients a little bit differently, and we can do injections and then put them on HUNOVA separately. We look at the soft tissues, the labral tears, the meniscal tear is our first case study. Looking at the lumbar facet arthropathy, my gosh, all of our patients had some kind of degenerative back problem, but we were helped to see what may need treatment, such as an injection to the back, such as our complex diabetic man, and that last case that we can hold off on any injections to the lower back because the treatment needs to be addressed at the balance in the foot. In a neurological patient profile, we're looking at peripheral neuropathies. We are trying to develop ways that we can see how to change our protocol, develop a special, in a sense, of our own index from the HUNOVA, because we may see these improvements and again use it as encouragement for the patient to say, you know, we got separate problems, but you need to keep on working. The exercises are doing their thing. You're making progress, but we have a couple things to work on. And then radicular problems. Again, someone who may not be having muscular strength because of muscular weakness may be neurologically based. Chronic neuropathy or chronic radiculopathy we know affects people's strength, balance, and the like. So what are we doing? We are using regenerative medicine for our practice, but we are using HUNOVA for research. We are using the ways we can collect this data, looking over time. We're trying to develop our protocols. So currently we are a musculoskeletal patient, and our musculoskeletal protocol is looking at HUNOVA assessments before or at the time of the injection. That's our starting point, as we indicated before. We look at the injection, what type of injection we're using, where the injection is going, and we track that in a sense of protocol, hoping that we have benefit for all of them, knowing very well that some may respond better than others. And what do? Well, we reassess. We now have objective evidence through HUNOVA and through the exercises that this person will be assessed every 3 months, looked at a period over a couple of years as we're collecting the data, and we can hopefully retrospectively go backwards to say, hey, we got to change our protocol for the hip versus the knee, or again, make our adjustments. And so we're looking at that data for a couple of years. In our neuropathy or neurological protocols, a little bit more difficult for us to try to capture how to really best assess it. We do the same HUNOVA assessment before or at the time of the injections. Here on this right-hand picture, we can actually see our apparatus. We have a stimulating device that here in this picture, we're actually about to inject someone's sural nerve. So the stimulator creates the dysesthesia or the odd feeling along the nerve pathway, and we know we are closer to the nerve without causing a harm, and we inject around that nerve. We inject the sural nerve, the peroneal nerve, and the tibial nerve divisions around the foot and ankle as a direct injection, and we also then infuse exosomes as a systemic treatment to hopefully capture ways we can treat the neuropathy protocol, the neuropathy patient. In our protocol, again, we are given these injections. We are looking at the patient every 3 months, again, testing them for a couple of years, but we are looking at the different ways to study. Well, not everyone can afford or do we do exosomes. So the exosome infusion is an option at this point. We would like to give the exosome infusion at the early onset and then quarterly for the first year, and then every 6 months the following year. And we're making our adjustments to the same thing from a direct injection following that data, because again, we can see if the person's complaining of neuropathic symptoms, or again, are their data on HUNOVA changing. And why do we like this? Again, as I mentioned a couple times, HUNOVA has been wonderful in helping us to standardize our protocols. It's more objective. We can see numbers of which we clinically may miss. We are using the falls prevention program, such as the Silver Index. We're using the performance index for the right candidate to use that as a assessment tool going into the future, and looking at our protocols of strength training and our clinical protocols of ways in which we can adapt or adjust our treatments to what type of regenerative medicine protocol or solution, or hopefully try to make the right choice and not inject treatment, or to not treat the pictures, but actually treat the right candidate. So we've really enjoyed the use of the HUNOVA device, and definitely it's making a difference in our practice. We hope to make further progress and come back with some hard data as time goes on. I hope you all enjoyed our brief webinar. It's a very brief overview as we start to use this equipment to help enhance our practice. And Colleen and I will be open for questions.